Okay, so let's talk about causality then. So, association versus causality. Epidemiology, one important point is epidemiology never proves that a certain exposure causes a certain disease. It can only demonstrate a strong association. So, once you hear decision makers, for example, saying like, oh, this study has proven that, you can always, almost always be very cautious, because rarely studies always show that it's very likely maybe that something is associated and this is a cause for that, but proof is a very big word. So a cause, what can be the cause? By the definition by Collins is in the English dictionary is a person, thing, event, state or action that produces an effect. This can be the cause. There are three forms of causes: necessary cause, sufficient cause, and component cause. A necessary cause is something which has to be there. Like, you can only develop tuberculosis if you have been in contact with the Mycobacterium tuberculosis. So this is necessary. But does everybody who gets in contact with the Mycobacterium tuberculosis develop tuberculosis?
No.
Why not, Mian? Because this is a necessary cause.
Yeah, but there are other factors that are influencing it also, like the nutritional status of the individual, the immune status of the individual. So yeah, it depends on that too.
Exactly. So we don't only have necessary causes, but also sufficient causes. For example, iron deficiency can lead to anemia, but there are lots of other factors which can also lead to anemia. And especially we have component causes. And this is what one of the things I tried to tell you already on day one. Actually, the reality is that almost nothing is monocausal. Okay, if I take a hammer and hit my finger, then this is monocausal, but it's maybe because I became a bit crazy. So there are other factors which caused me to do so. So that usually there are lots of factors. For example, you remember from Bradford Hill, myocardial infarction is one of the causes of smoking. But there are also other factors which can cause myocardial infarction. It's also hypertension, genetics, too little physical activity, diabetes, you name it. There are lots of factors. So the world is in many ways consists of component causes. The world is usually multi-causal. Okay. If we want to find out whether an association which we observe is really real, I would be very reluctant if the first study now shows that the first study in the world has shown that this new medicine cures COVID-19 without any problems. With a single study, I would be interested, but I wouldn't be convinced, because a single study can be open to bias, confounding, and statistical error. Okay, so, and also it depends on what kind of study design was it. So my first question usually always is, when you hear about a study, first try to figure out what kind of study design is it. If an ecological study shows us, a new ecological study published in the United States of America has shown that if you, I don't know, if you drink a glass of orange juice every morning, you will not develop COVID. Those people, because in those countries where there's more orange juice being consumed, theoretical, this is, there would be less COVID. Does this mean would you change your behavior? This would probably not be very convincing. An ecological study is or a cross-sectional. The first cross-sectional study has shown this. Normally, one would go up the ladder of the strengths of different study designs. So a cross-sectional study is a relatively poor study design. It is good and interesting, but it's not so reliable if we want to come closer to causation. So you would probably rather also wait until a case control study, maybe a historical cohort study or a normal cohort study or a randomized trial has really shown this. And if several studies in the different study designs have all shown that the orange juice, or no, one of the things which has been really debated recently is like vitamin D supplements, that vitamin D supplements would really decrease the risk of severe COVID infection. If we see this in various studies and with different study designs, then I would probably believe it. And then I would still be wondering, but the more in this direction, the more reliable it would be. Okay? That's also why it is important for you to not only know one study design, not only a normal cohort study, that you know the pros and cons of the different study designs. Because once you read about a study, you need to grade, oh, this is a case control study, so it's a middle level of study designs. Okay, so is there also maybe a cohort study which has shown similar results? Okay, good. So let's talk about something nice, cause and effect of and confounders. In the north of Germany, they normally say these birds in storks, they bring babies. So if we have a baby, there must be storks around. Is this true? What do you think? There seems to be an association in northern Germany. In several. I also read about a study in Europe, looking at different European countries. The more storks nesting on chimneys and on houses, the more, higher the numbers of babies was born. So does it mean storks are the cause for are causal for having babies? Jennifer, I know you have babies. So do you have storks around? Do you have kids? Do you have storks around where you're living?
Of course, no. It's it's just like believing in Father Christmas and the Tooth Fairy. So
it's true, but if you look at the raw numbers, this is fictive. But I can show you, at least give you two studies where there seems to be a really strong association. So does it mean? Yeah. So why do we conclude? Okay, because we know better. But why do we don't conclude that storks bring babies? The association is there. It's statistically significant. So it must be causal, or not? Hatem, please.
Yeah, it might seem so, but I think there is no robust evidence to make this association as a causation.
Right. So we need to be a bit more careful. Thank you very much. Okay, the question would be, storks bring babies, or do babies bring storks? Could also be like, but it becomes a bit weird. Okay, storks, because we have the same association. Maybe it's not this. Maybe there's another factor. Numbers of warm chimneys and the numbers of storks nesting on chimneys might be associated. So what is it? Warm chimneys, storks, or babies? Oh, very complicated. Okay, but let's have a look at another example, which you know very well. Miasma and cholera. You remember on day one, we talked with Jon Snow, and at that time it was not just a fictive, funny story, it was reality. People thought the scientific community was quite convinced that miasma caused cholera. And you see, the feet above the River Thames, the higher you were living above the River Thames, the lower the number of cholera deaths per 100,000 occurred. So it seems to be that because this miasma, this heavy air, is more at lower levels, was the theory. So how could they find out that? No, it's quite convincing. Miasma is probably causing cholera. What do you think? How do you interpret this? It's not always so easy, isn't it? With the storks, it's easy, but this way, it's so from this seems to almost prove the theory of the scientific community 170 years ago. Okay, higher above the river, a linear relationship with concentration of bad air, miasma, which is the cause, but it's at the same time normally the castles are on the top of the mountain, so the rich people usually always lived very high. In lower areas close to the river, there was overcrowding. The further away people were more affluent, and contamination of the water supplies was also an important factor in the 1850s. So to understand this better, 30 years after Snow, Robert Koch, a famous microbiologist from Germany, came up with his postulates. And he had these 4 postulates really trying to understand whether, can be the cause for an infection. He said the microorganism should be found in all cases of the disease in question, and its distribution in the body should be in accordance with the lesions observed. Okay, so he tells us about the fundamental cause. So the bacteria must be there. If you want to die, if you have a patient with TB, he or she must have the tubercle bacteria in them. Secondly, the microorganism should be grown in pure culture in vitro for several generations. Okay, this is a very microbiological point of view. Third, when such a pure culture is inoculated into susceptible animal species, the typical disease must result, so that you can reduplicate, that you can take the bacteria and that you can infect, that it can also be infectious. And the fourth, the microorganism must again be isolated from the lesions of such experimentally produced disease. Okay, so this was his approach to prove that the miasma theory practically was not right. So if you can show all this, it's probably a microbiological problem. Okay, but we're not in microbiology, we're talking about epidemiology here. So how we can, if we have results of a study, we don't necessarily can reduplicate it and we can reduplicate, but we cannot always find microorganisms if we're talking about lung cancer, for example. So in 1968, quite a long time ago, 50 years ago, more than 50 years ago, the boss of Richard Dawes, Bradford Hill, this was his boss, came up with his criteria for causality. For a large extent, these are still used today. So it helps. They are not, we don't have a statistical test which tells us, hey, this association is there, so it is causal. This is not there. But using some of these criteria can help us to weigh whether an association is causal, likely to be causal, or likely not to be causal. And this helps us. That's why an epidemiologist, as I said before, would have difficulties to say yes or no. He or she will normally answer, as some of you did in our course already, yeah, it depends. Depends on different things. And these 9 criteria, some of them are really important, and I want to show them to you and discuss them with you together. Okay. First, strengths of an association. Strong associations are more likely to be causal than weak ones. For example, I've got also prepared here all this. Smoking more than 20 cigarettes a day has a relative risk for laryngeal cancer of 20. And not so this seems to be 20 times more likely to develop this kind of cancer if you smoke. It's very likely. Or do you remember trichinosis in Paris? If you eat raw horse meat at that time, if you had eaten raw horse meat at that time on a daily basis, your relative risk or odds ratio in this case was about 340. Do you think this is rather this is causal, or does this strong association help to think this is more likely to be causal than not causal? Okay. But so this is clear, very simple, but it's not that easy. Not all stronger associations are causal. For example, do you, if you think about Down syndrome and birth rank, almost all kids with Down syndrome are the last children in their family. Is this because the last children normally develop Down syndrome? Do you know trisomia 23?
No, it is not because being a last child. Sometimes it could be the first child even.
Right. But why is it often the last child? Ibn Mido, you were first.
Okay. Prof always asks the next question, not the next for me. Can you hear me? Hello. Okay, yes. So most times it happens because of the age of the mother. Right. So that's what happens. So it could be first if the mother is older.
Right, exactly. It's the order is only is maybe a confounder. It's only associated with the age of the mother. Aida.
If like for the last children, sometimes they stop trying to have children because they had a child with a Down syndrome. So maybe with this sentence that the last children, maybe this is the cause.
Exactly, it's a combination of both. This is the other factor, because a child with Down syndrome, they can be really lovely kids, very cute, and but they need a lot of help, and therefore often parents who have a child with Down syndrome then decide, okay, we need this child needs, or the other children we had before and this one fill our day, so we don't want another one. Exactly. Okay, and weak associations do not rule out causality as well. Passive smoking and lung cancer has a relatively small relative risk, but there have been many studies which indicate that it's probably still one of the causes for lung cancer as well. So yes, it is a good one. It's if we see a strong association, but still it depends. We have to have a careful look. Okay. The second Bradford Hill criterion is consistency. Repeated observations of an association in different populations under different circumstances give us a feeling or an indication that this association might be causal. That's what I tried to say with the different study designs before. If we consistently see similar results in a case control study, in a cohort study, in a randomized clinical trial, then it's more likely to be causal than not. So, for example, smoking in lung cancer has been shown in more than 100 studies over 30 years as an increased risk. So this is one of the few things I would really say, yes, there's so much evidence that it's very, very, very likely to be true. Lack of consistency does not rule out causality on the other hand, unfortunately. For example, if complementary components causes not component causes, so which are also relevant, are not present to complete sufficient cause, then we might not even see see the effect, even though it's there. There was a study some years ago about tampon use on cause of toxic shock syndrome. It was famous in the US that there were super long-lasting tampons. At least they could suck up lots of substance for people, for women in their period, and some women forgot to take them out, so let them in for too long, and this developed a toxic shock syndrome. But if you use them appropriately, you won't see a problem. If you just use them inappropriately, it can be the cause. So consistency can only be apparent when all relevant details of cause are understood. But rarely we do understand all the causes. Maybe for lung cancer we understand to a large extent, but for new problems we often don't. So we have to be careful. But I would still prefer. I would still not say, like, if the first study has shown that some association is there with whatever study design, I would be reluctant until I see a few more. Yeah. Okay. Third factor, specificity. A cause leads to a single effect, not multiple effects. That's what Bradford Hill said. What do you think about this criterion for causality? Yes, Aida, please.
I think there should be a more likely this is the cause than, this is 100% the cause. There should be a little of some percentage that there is an unknown causal factor other than the one that appears 100% to us.
Aida, I agree with you on this, certainly, because I doubt where we will ever really know all causes for something. That's a one point. But this specificity also says, like, a cause leads to a single effect. Do we have, if from our experience, even in our course, do we have causes which are, do we only know about causes that lead to a single effect, Jennifer? Jennifer's gone.
For an example, I can think of one right now, but I know that there could be a cause that leads to several or multiple effects, and not just one effect.
Absolutely. Yeah. So, but Hatem, maybe you have an example.
Yeah, I think also, in my opinion, I think it's not totally correct because, for example, smoking cigarette affect the lung, affect the cardiovascular system, and it has like multiple effects.
Absolutely. That's an interesting idea, but it's one which we don't share so much. Aida.
Your example, sir, with the TB, the microvascular TB would lead to TB. So this is a cause for this disease.
Exactly. There are some which really, yes, it holds for some, but it doesn't hold for all. And therefore, it's not a good criterion at all. I agree. Mian, you wanted to say something?
I would just like to add with Aida, it's mostly with infectious diseases where you define something, but then again, there are other factors that are involved. And what comes into mind with specificity is this specificity and sensitivity tests with, yeah.
That's true. That's more about tests as well. Yes, yeah. And it's true for infectious diseases. The pathogen is a necessary cause, but as we also said with TB, for example, most of us, I think many of us, do carry the TB bacterium with ourselves because we once got in contact sometime in a bus or wherever. So I think certainly many of us do have TB with us, but we do not have TB. We have the bacterium, but if we get weak and old or so, we still might develop the tuberculosis, but not necessarily. Yeah, so it's not specific. okay, the TB bacterium causes specifically only TB, but there are many other causes which can cause lots of factors. But Anshu, you wanted to say something.
So I think for me, the best way to explain the specificity is that it depends on the disease, it depends on the situation. It can lead to one single effect, like either said, but then most of the times we see there are like nothing is monocausal. Similarly, it's not like one leads to just one.
Right. And interestingly, isn't it, even though this is one of the famous Bradford Hill criteria, it's a very often used criterion, these criteria, but we, even as young epidemiologists, we feel like, okay, some of them are really useful, this one might not be so useful. You always have to decide for yourself, you have to understand, okay, this one is not very valid. Causes of a given effect cannot be expected to lack other effects on logistical grounds. Why not? And main argument of those seeking to exonerate smoking as cause of lung cancer. Yeah, no, we don't want this criterion to be taken too seriously. Nevertheless, the fourth criterion of Bradford Hill, temporality, I think is a really good one. Exposure must precede disease. This is very important. So only criterion which is necessary for postulating cause and effect relationship. So this is a very important one. And therefore, we have to choose before we want to decide whether an association is properly causal. In our understanding, we want to decide for the right study design. So with a cross-sectional study, we can get a good indication, but we certainly cannot judge on causality, because you remember cross-sectional study, at one point in time, I measure disease and outcome, exposure and outcome, and to judge about temporality, we have to be able to judge what came first. Any comments on this? It's so clear. Okay, so which study design is very useful for answering whether temporality is given here? Which study design would you prefer to see?
Case control study.
Case control.
Yes, to some extent a case control, but
And even the cohort
and RCTs.
Exactly, cohort study or RCT are, by definition, you ask them before they get exposed or before they get ill, and not after. With the case control study, what kind of problem could we still have? It is trying to answer this, but we still might have a bias which might cause problems here. Aida.
The recall bias.
Sorry?
The recall bias.
Recall bias, exactly. Recall bias, exactly, because people might not remember so clearly whether one of my typical examples, which I mentioned, probably I mentioned it already before, also in our course, for temporality is very important. For example, if you look at gastric ulcer and milk product consumption. If you do a case control study, people might not remember when they started drinking lots of milk and eating yogurts or lassi, but they might, because with the first symptoms they probably started, and then the ulcer was diagnosed after. So you might end up with a problem of temporality here in a case control study. It might work, but you might also have to remember there might a recall bias might play a role. Okay, so but that was an important one. Biological gradient is often cited as well. Risk of outcome increases with increased exposure to this suspected risk factor. With other words, a dose-response relationship. So the more often you eat raw horse meat in Paris at that time, the more likely you were a case for trichinellosis. So with very little, you still had an increased risk if you only had once a month or so, but you still had a slightly increased risk. But if you had it every day, you had a huge risk. Dose-response relationship is a very good one. Or otherwise, risk decreases following removal of the risk factor is also a good factor. For example, when smokers stop smoking with at the age of 30, they will still gain almost normal life expectancy afterwards again. Yeah, more smoking causes more opportunity developing lung cancer, and more frequent consumption of horse meat, we talked about, increases the risk of trichinellosis. Okay, that's a good one as well, I would recommend. Plausibility, Bradford Hill had so many, I don't know, the Bradford Hill criteria are 9 criteria. This is really unusual, I think. Would you also have come up with 9 criteria? I think maybe a few less, or at least 10. I would have come up with a 10th one, because normally everybody thinks around like maybe 10, but 9 criteria is a bit odd, isn't it? Anyway, another one is plausibility. Consistency with current biological knowledge about the disease. This is a factor which is often also cited. What do you think about this one? Aida, please.
I think, sir, it resembles the example once you gave us about the trichinellosis, and the people believed that mostly it would be from eating pork. So it depends on their beliefs, or what that was believed in that case in such a situation. So
Yes.
definitely it wouldn't be. It could be. It could give a percentage of correctability, but not. We cannot depend on it.
Absolutely. I completely agree with you. This is a good example. Nevertheless, very often these days, even these days, I hear that you see an epidemiological association, for example, also very, very strong, like with the trichinellosis, and people want to first find out what is the biological explanation for this. Sometimes we don't have a biological explanation, like, for example, and yeah, because it's based on prior beliefs. Horse meat as cause of trichinellosis is implausible. And still today, I had the horse meat example in the bachelor students yesterday. And there I really asked, there were several of them who have horses at home and so on. And they all believe maybe a horse might bite if you hold him a steak in front of them, but they will not swallow, they will not eat, because and they have big problems. It's illogical, but still somehow it must be possible because the association is extremely strong. I still have the tendency to believe that eating raw horse meat can, if the horse is infected, can be the cause for trichinellosis. So the biological explanation is sometimes difficult. The same we saw in London, because they didn't know about bacteria at this time. So it is what John Snow found out was totally illogical for them at that time. And so, so I think plausibility, even though it's still used every day, please think about it. When you are with the next epidemic or next health problem where you're dealing with, if you have got very strong epidemiological evidence, it might be useful to follow the knowledge from this, even though you cannot prove a biological explanation, I think. Okay, so today, given vast knowledge of physiological, biochemical, pathological processes, scenarios easy to construct. Yeah, with other words, what I want to say here is, I often feel that one can come up, you can always think about something as a biological explanation, even though it's not there and not proven. Okay, to give you another example, which might be more helpful. Do you know, especially my African colleagues here, do you know anything about male circumcision and HIV infection? Have you heard about this? I'm sure some have. Jennifer, please.
It's generally believed, and I think even World Health Organization promotes circumcision as a way of reducing the incidence of HIV infection.
This came only out a few, no, 10 years ago, 15 years ago. And when I first read about it, I was also really impressed and thought, like, can this be true? And I, at some EU meetings where I worked for the European Commission, I met one of the researchers who did a randomized clinical trial on this in Africa, especially in areas where the HIV transmission is mainly heterosexual, like in Africa. In sub-Saharan Africa, you have they have shown, and in good studies, first in case control studies, in cross-sectional, first in ecological, then in cross-sectional, then in case control studies, in a few cohort studies, and later on in 2 randomized clinical trials. If you circumcise a male prepucium, there seems to be a strong protective factor for HIV infection in a heterosexual way. Wow. But still, I don't know, do you know why this is the case? Because I always was wondering, like, how can this be? If you cut something off, you're more protected. It's only a little bit of skin, okay, but how can this be? Ida, please.
I'm working in a hospital and with the surgeons that do circumcisions in adults. The patients come repeatedly with infection, so that this part of the skin it harbors microorganisms. So like it would be a place for harboring and a lot of different organisms. So some go to the surgeon because it is known now that especially if that patient have recurrent infection, UTI, or even affecting his wife. So the medical and surgical treatment would removing this skin to remove the place where the microorganism gets harbored.
Yes, but HIV for bacteria, I can understand. Okay, HIV is different, but you're right. Maybe if there's more inflammation and so on, this is a good explanation. Could be a good explanation for it. I'm happy that we're here mainly medics, so that we can discuss a topic like this just in a way. With the bachelor students, I would never use this example because it's difficult for them. But this is a good explanation. It could be a good explanation in some cases. Ibumide, you want to say something?
Yeah, I just wanted to say that I guess definition is understandable, but like you said, HIV is a virus. And I think that a virus stays outside, there's an amount it can stay outside the host. So I'm just trying to think of how much more is the virus, just putting a question to you, is the virus going to stay under the folds of the uncircumcised, the skin, the folding of the skin, or does it make that the skin is sensitive and this can cause incisions and then thereby allowing the person to contract the HIV virus? I'm just putting the question on you because I know that it's a virus, not a bacteria.
Exactly. But okay, this is a practical explanation of yours and Aida, but still, this is a minority of chronic infections around there. But the epidemiology showed really strong evidence. I mean, that's why WHO recommends it, and the 2 randomized clinical trials showed strong protective evidence there, so that WHO recommends it, and the effect is for heterosexual transmission seems to be as strong as a moderate vaccine almost. So that's why it's highly recommended. Aida, let me just give you one more sentence on the point is the explanation which was given afterwards was not the infection around the preputium, but it was the where the Langerhans giant cells in the preputium, which are supposed to be more prone to help to the HIV virus to be absorbed in some ways. And this explanation for me as a simple epidemiologist was rather very microbiological or histopathologically very complicated, and I'm not so convinced about it. What I want to say is, like, whenever you see a strong association, you can always develop a hypothesis why it works. But if you see that there's a strong association, plausibility, if it doesn't sound plausible, but if it's there, I wouldn't exclude it. So you can always come up with an explanation. But Aida, you
Yeah, just to add, for general knowledge, there are skin viral infections, like warts. There are a lot of warts due to virus, not bacteria.
right.
So there are certain viruses, chickenpox, that what's called the belt, like it happens in the skin on the chest like a belt. Apart, another form of chickenpox on the skin. So there are certain viral skin infections.
Right. Okay. All I wanted to say is, like, with lots of explanations now, plausibility is often used in our current understanding still, in our scientific community today. But still, you have at least two examples, the horsemeat and the cholera in 1850s, that even if we do not have a biological explanation, but if we see a strong epidemiological association, it might not exclude that this might be causal. That's all I just wanted to say. Okay. Coherence is another factor which interpretation of cause-effect relationship does not conflict with what is known of the natural history and biology of disease. For my understanding, is also a criterion which is close to the previous one. Smoking in lung cancer, histopathological effects of smoking on epithelium, difference in lung cancer, incidence by sex, and so on. Coherence and plausibility, I wouldn't be strong factors in my understanding. So the absence of coherence cannot be taken as evidence against causality, in my understanding. Analogy is another one. Existence of other cause and effect relationships analogous to the one studied supports causal interpretation is also used in other ways. So when I worked for the EU, I know that there were people who strongly are working against to make animal experiments unnecessary, and they just try to use analogous explanations. So if a particular drug is a potential carcinogen, different drugs of the same class may also be a carcinogen. This might be true, but I think it's a weak criterion for causality. Useful for speculating how risk factors may operate in different contexts, but also a relatively weak one. So in summary, these were the 9 criteria. Maybe he tried to get to 10. That's why he had a few weak ones in there, and he couldn't come up with a 10th one. I don't know. In summary, what Bradford Hill wrote himself is, none of my 9 viewpoints can bring indisputable evidence for or against the cause and effect hypothesis. So none. Yeah, maybe temporality, I think, is an important factor, but they are not exclusively. Temporality only necessary criterion. All other criteria neither necessary nor sufficient to determine causality, but still helpful. So if you want to if you're wondering, evidence from several sources other than epidemiology required to demonstrate causality or to prove that one thing causes the other. But we can still see strong associations. So association versus causality, epidemiology never proves that a certain exposure causes a certain disease, as I started off with. It can only demonstrate a strong association, and that may be via a confounder. So we still need to be careful to wonder what it is, but these criteria can help us to weigh, and that's why, as I'm saying this again, sorry, but that's why epidemiologists are normally very cautious in their explanation. So perhaps it's true after all, who knows what plays a role here. Okay. Oops.